We're going to start the afternoon with mediastinum and cases. And so, when we're talking about mediastinum, we're going to be talking about a lot of masses because localization and characterization of mediastinal masses is probably, one of the big things we do. And on a plain film, you have to learn how to localize these things to a particular compartment of the mediastinum. And a lot of that involves the silhouette sign. We talk about the silhouette sign in the context of right, middle, differentiating middle from lower lobe pneumonias and things like that, but who cares whether the pneumonia is in the middle or the lower lobe, but we do care about where mediastinal masses are. So, particularly on a chest x-ray, use your normal lines and stripes and see what's silhouetted out, and that'll determine what compartment is and what your differential diagnosis is. Here's another example. So what is silhouetted out in terms of localizing it from anterior to posterior, in the anterior mediastinum, middle mediastinum, or posterior mediastinum. And then there's just some classic locations that we talk about, such as this one, in the angle here, the cardiophrenic angle, which we call it. Okay, young male, cough. This is kind of a radiology classic, although it's not well known. A funny story, we had a resident who was on chest, and one of our other attendings, Dr. Webb, showed him this case, and he said, this is a rare disease. And he came to me and he said, Brett, how in the world would you get this? Dr. Webb showed me this rare disease. And I was like, oh, it's this so-and-so. And he said, and that was, I had seen the case before and knew it was this rare disease, and we were playing with him a bit. But this is sort of a classic young male with a parahilar/hilar mass as the abnormality. Okay, another one, a little bit more subtle. You can kind of see a subtle contour deformity on the right. And then you can appreciate how that's affecting the carina. And then what will be your differential from there. The way we talk, you'd think that all of our attendings are like evil, pimping the residents and playing with them about different cases, Castleman's disease and things like that. But we're actually nice people. All right, last case. This is a classic sign in radiology. So where is this located and how do you know? And you should know by the something sign, which I won't reveal yet. As you probably all know, the mediastinum is divided into certain anatomical compartments, anterior, middle, and posterior. And generally you can draw the anterior mediastinum. This is what's usually used, the anterior wall of the trachea, and then the posterior portion of the heart. That forms the anterior mediastinum. The posterior mediastinum is about 1 centimeter posterior to the anterior vertebral body margins and going backwards, and then the middle is everything in between that. And so whatever mass you see, your differential is going to depend upon which compartment of the mediastinum is affected. And so here we see a big mass that's projecting down into the cardiophrenic angle. And the key is, what do we see obscured? What normal structures, lines, stripes, etc. is obscured, is silhouetted out, and that will tell us how to localize it in the front to back plane. Okay? So what do we see? What's missing here? Well, the right atrium is missing. So the right atrium is obscured here, and in general, we consider the heart an anterior mediastinal structure. And so that'll give us a clue. So anterior mediastinal stripes and lines would be the heart borders, primarily. The middle mediastinum is going to be SVC contour, if you see it, or right paratracheal contour. There's going to be the arch and the aorticopulmonary window and the pulmonary artery. And what this is the azygoesophageal recess. So those are lines and stripes that may be obscured with middle mediastinal masses. And posterior mediastinal masses are going to be mainly the paraspinal lines and the descending thoracic aorta. Okay, so look to those structures to localize masses. This is the anterior, so let's start with the anterior mediastinum. This is the medical student differential, the terrible T's, which you all learned in medical school and have continued to learn until now. And probably it's always in the back of our heads because that was a particularly formative time. But in reality, the good differential is the good radiology resident and attending differential, which is actually 5 things. And you can remember the T's, but you gotta remember, instead of saying thymoma, you should say thymic tumors, tumors of thymic origin, because you don't want to go through the whole list of thymic tumors when you're talking to someone about a case. You don't want to say, oh, this could be invasive thymoma or non-invasive thymoma or thymic carcinoma or thymic carcinoid or primary thymic lymphoma or primary thymolipoma, thymic cyst, nodular thymic hyperplasia. And the person's going to say, please stop. Tumors of thymic origin, okay? Same thing with germ cell tumors. Say germ cell tumors, not teratoma, because you don't want to say mature teratoma and immature teratoma and seminoma and embryonal cell carcinoma and choriocarcinoma, germ cell tumor. Lymphoma, and that includes lymphoma and lymph node masses, reactive lymph node masses from things like sarcoid, infections, metastases, and then thyroid and parathyroid tumors, either goiters or malignancies or ectopic parathyroid masses. And then there's lots of other stuff which is not as important, and particularly on a chest X-ray, but may be important on a CT. And there may be particular things to suggest one of these other anterior mediastinal mass differentials. All right. Here's this patient with the anterior mediastinal mass and an obscuration of the right heart. You can see this big, homogeneous, with a little bit of calcium or enhancement there, but very homogeneous mass in the anterior mediastinum. And so what do you want to ask? Age. So keeping your differential focused, you need to know the patient's age. And you can see that lymphoma is a very wide age. If you combine Hodgkin's and non-Hodgkin's, you're talking about young people and old people. Tumors, germ cell tumors tend to be young, people who are young, usually in their 20s and 30s or even younger, but under 40 in the vast majority of cases, whereas thymic tumors are usually over 40. So that 40 cutoff is pretty decent for differentiating germ cell and thymic tumors. So let's talk about thymic tumors. This is going to be the most common primary thymic tumor is the epithelial tumors, and it forms a fairly high percentage of mediastinal masses. The peak age is over 40, usually in the 50 to 60 range, and it's uncommon or rare even in patients who are young. Clearly it has an association with myasthenia gravis, as you know, and then there are several types of thymic epithelial tumors. Thymoma, either invasive or non-invasive, thymic carcinoma. And when these things spread, they tend to spread to local nodes in the mediastinum. They can also spread to the pleura, so in the differential of multiple pleural nodules, in addition to things like metastases and mesothelioma, you could consider thymic tumors. And then extrathoracic spread can happen, but is rare. So usually it's local mediastinal spread and pleural spread. Where do you see thymomas and other thymic epithelial tumors? Well, you see them most commonly in the anterior mediastinum in this kind of horseshoe-shaped, and you would be particularly looking at those heart borders to see that they're obscured, because that's a classic anterior mediastinal mass. CT scan, they're variable in various things. Some are calcified, some are not. Sometimes they have cystic components. Location is key. They typically they at least start where the thymus is. A normal thymus is located anterior to the ascending aorta and aortic root. So that's where they typically occur, although they can bulge out to the left or the right and kind of droop down. Occasionally they may be more posterior, but that's pretty rare. And then since the thymus, sort of migrates embryologically, they can be in ectopic locations such as the neck, but the majority are going to be in that prevascular space. Can we differentiate non-invasive thymoma from invasive thymoma? Well, sometimes we can. If there is a good fat plane between a single soft tissue tumor and vessels and various other things, it's usually going to be a non-invasive thymoma. If you see the bigger ones, the more heterogeneous ones, tend to be more aggressive lesions, so more of the invasive thymoma or thymic carcinoma, which actually are very similar. And then if you see pleural effusion and nodules, that's obviously going to be a more aggressive lesion, and then separate lymphadenopathy. So classic non-invasive thymoma is a solitary, isolated mass with preserved fat planes between it and vessels, without adenopathy, without pleural effusions, and pleural nodularity. Okay, so here's a beautiful example of that, a non-invasive thymoma, single homogeneous mass in the right location, right age. This is a 50-year-old patient, nice fat planes between it and the aorta. Here's another patient, correct demographics, bigger, more heterogeneous. We're starting to lose our fat planes, which isn't too helpful, but we see another little node here, which is a bit concerning, so size and extra, maybe a node involved, would make us think it's more of an aggressive tumor, such as invasive thymoma or thymic carcinoma. Again, those commonly look the same. Here's another example, nice soft tissue attenuation, homogeneous mass, but what else do we see in this case? This is not a simple non-invasive thymoma. We see pleural nodules, and we actually see some separate adenopathy away from the tumor, and here's another big mass over here too. So there's at least 3 masses in the mediastinum. Okay, so that's either going to be an invasive thymoma, like it was in this case, or a thymic carcinoma. It's not a non-invasive thymoma. So that's thymic epithelial tumors. This tumor is very different in that it's much more heterogeneous, and we see areas of both fat and bone, or at least calcium. We see a lot of mature elements. Those are the elements I would consider mature in this, and this is a mature teratoma. Germ cell tumors, common cause of anterior mediastinal masses. Relatively high percentage, and again, these tend to be in younger patients, so under the age of 40, usually 20s and 30s. There are various different types, which we'll talk about in a second. They are also most commonly in the anterior mediastinum, occasionally posterior, but most commonly anterior. Classic age distribution. The majority of these the majority of germ cell tumors you see are mature teratomas, and you're particularly looking for those mature elements such as fat and calcium. Males and females equally get these benign germ cell tumors. The vast majority of malignant germ cell tumors are seen in men. And benign tumors are often asymptomatic. They grow slowly because they are benign tumors. You maybe see it, pre-op chest X-ray, you see an incidental mass, or you're getting a CT to do for some other indication. Okay, the top three germ cell tumors are the mature teratoma, by far most common, and you can see a lot of mature elements in it. It occasionally may produce symptoms by rupture into the pleura or mediastinum, producing a mediastinitis or a pleuritis, similar to the same entities in the brain or something with CSF involvement. It tends to have lots of mature elements like fat and calcium. Number two is seminoma, which will look very different in almost all cases. It's almost always in men, and again, tends to be a relatively young age. And it tends to be a solitary, soft tissue attenuation, fairly homogeneous mass in that typical area. And it tends to have a pretty good prognosis, Lance Armstrong, for instance, although he didn't have a primary mediastinal seminoma, but similar thing. And then there's another mixed bag of tumors, the non-seminomatous germ cell tumors, which have quite a variable appearance, may have cystic areas, may have calcium, but they tend to be bigger, infiltrative appearing. They often are confused with lymphoma, given how infiltrative and invasive they look. And they tend to do pretty poorly, although there are improvements made in treatment. So examples, another example of a anterior mediastinal mass, big mass here. Looks like it's obscuring portions of the left heart border and a bit of the pulmonary artery. It's on the lateral view, it's probably somewhere in there, so it looks like an anterior mediastinal mass, mainly by the left heart obscuration. There's the CT scan, lots of fat in it and or fluid. The density of this was somewhere actually between fat and fluid. Lots of mature elements, that's a mature teratoma. Okay, here's the case I showed at the beginning. Pretty homogeneous, soft tissue attenuation mass centered in the anterior mediastinum, a little bit of calcium or enhancement there. This is a man, so with that soft tissue attenuation, doesn't look like it has mature elements, probably a seminoma. Here's case number one. Where is this located? Well, it's not next to the aorta, because we see the aortic contour very nicely there, both the arch and the descending aorta. I could sort of argue that the paraspinal line is there, which is a little bit hard to see, but it looks also like the last case, like it's obscuring a portion of the left heart border, so it looks like an anterior mediastinal mass. There it is. Anything characteristic about that? How is this different than in thymic tumors or germ cell tumors? Well, it looks very high density. It's enhancing quite avidly, and then you have these cystic components. And if I gave you a non-con, you would also see that it was high density in the non-con, which can be very helpful. This is a thyroid goiter that was projecting down into the mediastinum. And that's most helpful. Non-con CT, high density, intrinsic high density, and then this sort of patchy heterogeneous enhancement like this. Another example of a primarily anterior mediastinal mass. It looks like it is obscuring portions of the right heart border. The right paratracheal stripe looks like it's involved, so mostly anterior mediastinal mass. History would, I don't know, it probably would have led me towards sarcoid, but this also can be seen, uveitis diffuse, with this case. Very infiltrative appearing, not like a nice solid round tumor, it's more infiltrative appearing. And this is a case of lymphoma. What suggests lymphoma to me? Exactly this, a tumor that's very infiltrative. It doesn't produce a lot of mass effect in proportion to its size. So it's enormous, but the aorta is not narrowed, or the SVC is narrow, but not that much. Okay, it doesn't produce a lot of mass effect. Two flavors of lymphoma, Hodgkin's and non-Hodgkin's. Hodgkin's mediastinal adenopathy, very, very typical, and it tends to have a strong predilection for the anterior nodes. So these prevascular nodes in particular is almost all cases of mediastinal Hodgkin's will involve the anterior nodal groups predominantly. And when you have only prevascular nodes, that's very typical of nodular sclerosing Hodgkin's disease. But multiple nodal groups are commonly involved, so you see that plus others involved. And occasionally you see necrosis, unusual, and calcium's rare outside of treatment. Okay, non-Hodgkin's is a much more mixed bag with different appearances and different behaviors. It tends to be a generalized disease, so you'll have both chest and other organs or other portions of the body involved. Chest involvement is about half of the cases, commonly more than one nodal group. If you see isolated posterior nodes involved, that argues strongly against Hodgkin's and more for a non-Hodgkin's lymphoma. And the anterior predilection you see with Hodgkin's is not as common with non-Hodgkin's, okay? So here's a nice example of non-Hodgkin's lymphoma. Infiltrative appearing soft tissue mass, mainly in the middle and a bit of the posterior mediastinum surrounding the aorta. You see nothing here in the prevascular space. There was nothing else in the anterior mediastinum. If this is lymphoma, which is quite suggestive of based on imaging appearances alone, we would strongly think that this is likely a non-Hodgkin's lymphoma given its location predominantly and lack of anterior involvement. Pericardiophrenetic angle mass is a classic radiology differential, which includes what? It includes tumors of the anterior mediastinum. I've shown you a couple cases. Thymic tumors, germ cell tumors, etc., lymphoma. Pericardial cyst actually is probably the #1 cause of a pericardiophrenetic angle mass. And when you get a CT scan, you're doing it for, well, one, to stage it, but also to see, is it a cyst or is it something else like a nodal mass? Because a cyst, you would do nothing about. And sometimes the CTs can be diagnostic of a cyst, whereas all the other nodal masses you would see, you probably do something about, like a biopsy. Fat pad, clearly, you would do nothing about that. Hernias protruding through the foramen of Morgagni, which occur right here. That's where the foramen of Morgagni is. And if you have a big one, you can see fat and organs protruding through there and producing a cardiophrenic angle mass. Lymph node masses from lymphoma, from some tumors that spread in the abdomen, particularly the tumors that spread via peritoneal spread and protrude through that foramen of Morgagni like ovarian cancer. And then lipoma. So this is sort of a classic differential of a pericardiophrenetic angle mass. This is the patient, homogeneously low density mass in the pericardiophrenetic angle. I could put a Hounsfield unit number on that, and the whole thing was about 5 to 10 Hounsfield units. No enhancing components, no thick wall, nothing, no complexity to it. You don't need to do anything about this. This is a pericardial cyst or whatever, some sort of congenital cyst. Classically in this location, pericardial cyst. CT is diagnostic in this case. So that's anterior mediastinum. Let's move on to the middle mediastinum. The majority of middle mediastinal masses you see are lymph node masses related to sarcoid, infections, tuberculosis, fungal, cancers spreading to the mediastinum from either a lung cancer or something outside the thorax. Okay, that's the majority of mediastinal masses. There are some others, such as vascular abnormalities, or vessels in the middle mediastinum, or esophageal masses, because the esophagus does lie in the middle mediastinum. Very commonly, we see duplication cysts in the mediastinum, foregut cysts. So bronchogenic cysts, the classic location is subcarinal and paratracheal. That's the middle mediastinum. Trachea is also located in the middle mediastinum, so things like adenoid cystic, mucoepidermoid, squamous cells of the trachea, carcinoid, which is not commonly seen in the trachea, but occasionally. And that's a good middle mediastinal differential. But again, the majority of these are going to be some sort of nodal disease, either reactive or neoplastic. So let's talk about nodes for a second. When the nodes are densely calcified, you certainly know it's a benign process, and it's typical of old granulomatous disease, TB, fungus, sarcoid. The eggshell calcification, which Rick talked about a little bit, is classic for silicosis, but you can certainly see it with sarcoid as well. And we don't see a lot of silicosis these days. So sarcoid is probably statistically more common. You occasionally see it with treated metastases or treated tumor like with lymphoma. And then there's some uncommon causes of calcified mediastinal nodes, such as tumors and amyloid and Castleman's, which are rare birds. Here's an example of nodes, many of which are densely calcified. So we're just going to say that's likely due to old granulomatous disease. And this is a patient with sarcoid. Here's a node with these kind of punctate, thermomatous-like calcifications in a patient with thyroid metastasis to the mediastinum. All right, what about nodes that look necrotic or have low attenuation centers? If it's infection, it's very typical of tuberculosis and fungal disease. And if you see a node that's over a centimeter in the mediastinum, due to TB or fungus, it's usually necrotic. Okay? Once it gets to a certain size, it almost always necroses. But certainly metastases can do that. Renal cell is a classic one to enhance very avidly and produce lots of necrosis at the center. But a lot of the GI and GU tumors can do that. Certainly lung cancer can do that occasionally too. Melanoma, breast. Lymphoma occasionally necroses, is pretty rare. And then very, very rarely sarcoid. So mainly it's the first two we're thinking about when we see necrotic nodes. Here's active TB. You can see the enhancement at the periphery and the necrosis at the center. And then here's a patient with lots of metastases. What about nodes that are very avidly enhancing? Well, most commonly due to metastasis, and again, often it's the GI and GU tumors. Lung and melanoma as well can do that. Tuberculosis, if it's small, it can homogeneously enhance. Once it gets to be about a centimeter or two, you'll expect to see enhancement at the periphery and necrosis at the center. And then there's some rare things. Again, you don't want to necessarily talk about these if you don't know anything about them, but classically, Castleman's, angioimmunoblastic lymphadenopathy, those tend to show pretty avid enhancement. And then make sure you want to differentiate multiple enhancing nodes from a solitary mass, like what was the case here. This is actually a paraganglioma. So this is just an enhancing tumor, as opposed to this case, we have multiple enhancing nodes all over the mediastinum in someone with multicentric Castleman's disease. Okay, here was our classic case. Solitary parahilar or hilar mass in a young male. Pretty unusual for lung cancer, right, in this group, 32-year-olds. Any other, maybe a carcinoid, potentially. They can be seen in young patients. Maybe some sort of weird bronchogenic cyst. You'll sometimes see those in the lung. Usually those are mediastinal. This is kind of a classic appearance and age group for Castleman's disease. If they present, the localized version of Castleman's usually looks like this. Okay? Talk about that for a second. There are two subtypes based on pathology. The localized type is usually the hyaline vascular type. It occurs in young, often males, and it presents with a solitary enhancing, avidly enhancing mediastinal or hilar mass. The hyalin's the classic. And you take it out and they usually do quite well. The multicentric type is more common in older patients. You'll see multiple nodes. They in fact enhance less frequently, but they still may enhance quite avidly. And it's more aggressive. They tend to have issues with immune suppression and infections and things like that. And it has multiple associations, including the POEM syndrome, which is probably what this patient had. It's probably above the level that's required here. But multiple enhancing mediastinal lymph nodes, I probably would have thought this was metastases. The patient had no known primary tumor. You would expect TB to necrose here. So Castleman's was another thought, and that's what this patient had, multicentric Castleman's disease. Okay, what about tumors in the middle mediastinum? Metastases directly to the mediastinum are not common. I think the most common we see them from an extrathoracic primary is GI and GU tumors. Breast would be the other one, but that's not really extrathoracic. Other ones would be head and neck tumors. Melanoma would be a good one. And the location of nodal disease with suspected or known metastatic tumor may suggest where the tumor is. For instance, if you have paravertebral nodes, that's classically an abdominal tumor extending up. If you have superior mediastinal nodes, it's a head and neck tumor coming down. Internal mammary nodes are classic with breast cancer. Occasionally you can see with lymphoma as well. And then you have pericardiac lymph nodes. That's classically breast or particularly abdomen, the peritoneal spread tumors like ovarian and gastric and pancreatic and colon. Okay, so here's a nice example of a lymph node mass in the posterior end, mainly the middle mediastinum, very, very low down, just below, above the diaphragm. This was ovarian cancer, which is just extending right through into the mediastinum. Don't forget, sarcoid has a very classic distribution of lymphadenopathy, which is almost diagnostic, very, very symmetric, hilar predominant adenopathy, and you often have right peritracheal and aorticopulmonary lymph nodes as well. The key is the symmetry and the predominance of hilar disease. If you don't have hilar disease, it's usually not sarcoid. But if you do have this classic appearance, it's virtually always sarcoid. And isolated masses with sarcoid are pretty unusual. And you can memorize this stupid staging system, which is based upon chest x-ray, where you have hilar adenopathy by itself as stage 1. What's the importance of the staging system is that as you go from stage 1 to stage 4, the chance of it regressing spontaneously without treatment decreases. So at stage 1, about 90% regress without treatment. Stage 2 is a combination of hilar adenopathy and lung disease. Stage 3 is lung disease by itself, and stage 4 is fibrosis. Subtle contour deformity here, looks like a mass. Carina looks sort of splayed outwards. Let's see the CT scan in this patient. This is actually a bronchogenic cyst. Where's the classic location of bronchogenic cyst? Subcarinal and paratracheal. Here's the CT scan. Whenever you see a solitary, good-sized mass in any mediastinal location, consider one of these congenital cystic lesions like a bronchogenic cyst. And CT and MR both can be diagnostic, one or both in combination. So look low density in the CT scan, fluid attenuation, very, very bright on the T2, can be variable density in the T1 because of proteinaceous fluid or hemorrhage or superinfection or whatever. Subcarinal paratracheal, most common, but in reality you can see these things pretty much anywhere. So solitary, single, well-defined mediastinal mass, always at least consider this. And it can contain air and become infected, but it's really a typical solid mass. On CT scan, often it's low attenuation without any solid components, and in that case it's diagnostic of a congenital cystic lesion. Occasionally it can be higher density on a CT scan, in which case you can either do pre-post contrast CT, or we prefer really MR, you're looking for brightness on T2 and lack of enhancement on the post-gadolinium, and that's used for problem solving. Okay, when you see something that looks like a congenital cystic lesion, it can be an esophageal duplication cyst when it is touching or in contact with the esophagus. It can be a neuroenteric cyst, which are typically paraspinal and associated with vertebral abnormalities. Pericardial cysts, I've already shown you an example of that. And then don't forget, sometimes these mesenchymal tumors like this leiomyoma of the esophagus can simulate that as a solitary mass, but they should enhance and will be higher density on the pre-contrast images. Okay, last group in the last few minutes, posterior mediastinal masses. Number 1, in terms of your differential, is neurogenic tumors, either from the nerve sheath or the ganglion cell. You can also see all of these congenital cystic lesions in the posterior mediastinum, bronchogenic cyst, neuroenteric cyst, esophageal duplication cyst. Tumors coming out of the vertebral body into the sort of paravertebral soft tissues. Aortic aneurysms, like in the descending aorta. The descending aorta is a posterior mediastinal structure. Lymph node masses are less common in this location, more typical of the middle mediastinum, but you can see them here too. And then you can have esophageal tumors sort of extending back posteriorly. And then obviously this, don't forget the classic PIMP, which you'll see once in your lifetime, extramedullary hematopoiesis. Why is this a posterior mediastinal mass? Well, one reason is the paratracheal stripe's intact, so I know it's not next to the paratracheal stripe. And also notice that the ribs are splayed outward. So it's a classic posterior mediastinal mass. Mainly we're thinking of a neurogenic cyst, a neurogenic tumor, or some sort of congenital cystic lesion. This is actually a schwannoma. Here is an example of a schwannoma and a ganglion cell tumor. So this is nerve sheath on this side and a ganglion cell on this side. Nerve sheath tumors tend to occur in 30 and 40-year-olds. That's the peak age for those. They tend to be over not many. They don't extend over multiple vertebral body segments. They may extend into the neuroforamen or not always. They can cause some pressure erosion of the adjacent vertebral body or ribs. And they tend to often show almost fluid attenuation density, or fluid density on a CT scan, and may enhance quite homogeneous or heterogeneously. Ganglion cell tumors, usually in much lower age range. They tend to be elongated, sausage-shaped. They're over multiple vertebral body segments, and they otherwise have fairly similar CT findings to the nerve sheath tumors. Posterior mediastinal mass looks like it's areas of sort of fluid attenuation, also areas of enhancement, only one vertebral body segment. I want to know the age. This patient was 40. That's most likely going to be a nerve sheath tumor. This was a schwannoma. Why is this a posterior mediastinal mass? What's the sign? Well, notice how the tumor is well defined at the level of the clavicle. If the tumor extends above the clavicle in the anterior mediastinum, it's in your neck, and you're not going to see a border there. This is called the cervicothoracic sign, and it's suggestive that this is a posterior mediastinal mass. This actually was a giant cell tumor that started in the bone and came out of it and produced a paravertebral mass. And here's a patient with abnormal bones, diffusely, also has these symmetric paramediastinal masses, classic PIMP case, You'll see, again, see one in your life perhaps if you're an active chest radiologist. Here's a case of extramedullary hematopoiesis, and the classic is the appropriate history like thalassemia, the abnormal bones, and the symmetry of these paravertebral masses, which may over time just turn into fat once the patient's treated appropriately. Don't forget, in the differential posterior mediastinal masses, aneurysms. This is an aortic aneurysm. I've shown you this case already. And again, if anyone ever asks you, do you want to biopsy this? Always question whether you're dealing with some kind of vascular abnormality. Here's a big aortic aneurysm.